Hello everyone and welcome to the second session on reporting of oral carcinoma. I'll be discussing two important cases of tongue carcinoma along with my reports today. So to discuss any case of tongue carcinoma or even report any case of tongue carcinoma, we need to be very thorough with the anatomy of tongue first. The important structures that we need to be familiar with before reporting are the intrinsic and the extrinsic muscles of the tongue and the adjacent structures. Of course, MRI is a better modality as compared to a CT scan in case of tongue carcinoma particularly. But I'll try to show you some structures, important anatomical structures on this particular CT scan so that it is easier for us to proceed further. So these are the coronal sections, axial sections and the sagittal sections of the tongue, where we can see this in the pink, these paired genioglossus muscle on the axial sections, particularly at the level of mandible. We can see these genioglossus muscle. The bulk of the tongue is formed by this particular muscle. It's an extrinsic muscle. As you go further down, this V-shaped structure becomes actually geniohyoid with attachment to the hyoid bone. So it's a bit above the geniohyoid that you can see this genioglossus muscle, which forms the bulk of the tongue. It is a paired muscle. Now, adjacent to this muscle, what we can see enhancing this structure is the lingual artery. It's a very important structure to be seen on the coronal images because the neurovascular infiltration typically is determined by this patency of lingual artery. It is seen on the MRI as a flow void on the coronal sections. If the flow void is maintained, we can definitely rule out neurovascular infiltration. So it's a very important structure to be seen. Along with that, floor of the mouth is a very important thing to be commented on. The floor of the mouth, which is formed by the two important muscles, that is the mylohyoid and the geniohyoid muscles. So this is the mylohyoid, the entire sling that you can see in green. These are the mylohyoid muscle that you can see, and the geniohyoid muscle. This is the geniohyoid, which I said was in a lower section than the genioglossus muscle. The geniohyoid and mylohyoid form the floor of the mouth. These two important muscles form the floor of the mouth and their infiltration needs to be reported. Then another important muscle is hyoglossus muscle in yellow that is seen. This is the hyoglossus muscle. These are the coronal sections where you can see this hyoglossus muscle, and these are the axial sections where we can see this hyoglossus muscle. Between the mylohyoid and the hyoglossus muscle is the submandibular duct. Okay. And this is the submandibular gland that you can see. So starting with our first case today, so here's a 40-year-old male who came with an ulceroproliferative growth in the left side of the tongue. He's a chronic tobacco chewer, and this is the MRI done for this patient. These are the axial T1 weighted post-contrast images where we can see ulceroproliferative mass lesion, the left side of the tongue, which is not crossing the midline. Some enhancing lymph nodes are seen in the left submandibular region. It involves the floor of the mouth, the geniohyoid muscles and the mylohyoid muscles are not involved. These are the coronal images where again we can see the patency of the lingual artery. The flow void of the lingual artery is maintained, as you can see, and the mass involves the genioglossus muscle on the left side along with the intrinsic muscles. In the sagittal images we can see that bulk muscle, the muscle that forms the bulk of the tongue, is involved on the left side along with the intrinsic muscles of the tongue. These are the T2 weighted images, axial section, the intrinsic muscles of the tongue. These are the floor of the mouth, the tongue of the floor of the mouth, the geniohyoid muscles, paired geniohyoid muscles, the intrinsic muscles. So on the coronal images, we can see that these are the paired anterior belly of digastric, the sling of mylohyoid, and the paired geniohyoid muscles, which are relatively free. On the left side, the genioglossus muscle and the intrinsic muscles of the tongue are involved. Some nodes are seen in the left submandibular region. This is a report I had given. Ill-defined heterogeneously enhancing ulceroproliferative mass lesions. It is important to be mentioned which type of morphology the mass lesion is, whether it's proliferative, ulceroproliferative, ulcerative mass lesion. And the size is very important of that particular tumor because more than 4 centimeters advanced stage. And it involved the left hemitongue with a depth of invasion. So depth of invasion is very important to be given. I'll show you how to measure it in my next case. The lesion does not cross the midline, and it is very important thing to be mentioned in the report, and it involves the intrinsic muscles of the tongue on the left side and the left genioglossus muscle. So all the involvement of the intrinsic muscles and the extrinsic muscles of the tongue are to be mentioned in the report. There was no obvious involvement of the base of the tongue. So base of the tongue actually it is beyond the circumvallate papillae, which are not actually seen on the imaging. But what we can do is on the sagittal images, we can draw a line, vertical line from the uvula to the hyoid bone. And beyond that line is the base of the tongue. So this was not involved in this case. The muscles of the floor of the mouth, which I showed, geniohyoid muscle as well as the mylohyoid muscles, were all free of the tumor. The phlovoids of the lingual artery, which I showed on the coronal images, were maintained, and hence there was no evident neurovascular involvement. And the mandible, which was correlated with the CT scan, there was no involvement of the mandible or infiltration of the mandible as such. And the tumor belonged to T4A stage. So TNM stage of oral carcinoma, all the oral carcinomas are the same. There were multiple enlarged homogeneously enhancing lymph nodes in the left submandibular region. That is the drainage territory of the left lateral tongue. Coming to our next case, so this patient presented with a proliferative mass lesion on the right side, right lateral aspect of the tongue. Again, a chronic tobacco chewer. And these are the T2 weighted images, axial section, where we can see that this mass lesion is seen, which is involving the extrinsic. This is a proliferative mass lesion, as we can see, exophytic mass lesion. And here I am calculating the depth of invasion. Now the depth of invasion of this mass lesion is calculated from the margin of the tongue, not from the exophytic component. How much it has infiltrated within the tongue from the margin of the tongue, not including the exophytic component. So this is the depth of invasion of this particular tumor. And this particular tumor involved only the intrinsic muscles of the tongue. There was no obvious involvement of the genioglossus muscle or the muscles of the floor of the mouth. These are just sagittal images. The patient was not very cooperative, so very good scan could not be obtained. These are the coronal images. Again, the patient moved a lot during the scan, even after giving propofol. So these are the coronal images where we can see that this lesion, the right lateral aspect of the tongue, proliferative lesion, is actually involving the intrinsic muscles only, not the muscles of the floor of the mouth or any extrinsic muscle of the tongue. So this is a report I'd given. It will define heterogeneously enhancing, partially exophytic proliferative mass lesion, which was seen in the right lateral aspect of the anterior tongue with the depth of invasion of 11 mm. The lesion involved the intrinsic muscles of the tongue on the right side. There was no obvious involvement of the extrinsic muscles of the tongue or the muscles of the floor of the mouth. The phlovoids of the lingual arteries were maintained, hence ruling out any evident neurovascular involvement. There was no involvement of the mandible, which I had gotten a CT cut as well of this patient. There's no involvement of the mandible as such seen. Multiple enlarged nodes were seen on the right submandibular region, which is the drainage territory of the right lateral aspect of the tongue. The carcinoma belonged to T3 stage. We'll come to TNM staging of oral carcinoma. One case was T3 and other case was T4. So in both the cases, our depth of invasion was more than 10 mm. But the first case, the tumor size was also greater as compared to the second case, and hence it was T4, while the second case was T3. There's no obvious involvement of the adjacent structures like maxilla, mandible, maxillary sinus, or skin. and there was no involvement of the masticator space, the pterygoid plates, or the skull base, or the internal carotid arteries that was seen in either of the cases. So in any case of tongue carcinoma, whether CT or MRI, all the important things that are to be assessed are the size of the tumor thickness, extension across the midline, extension beyond the intrinsic muscles of the tongue, and involvement of the adjacent structures like neurovascular bundle, submandibular duct, and the mandible. The anterior tongue drains into the submental nodes, while the lateral tongue drains into the submandibular and the upper jugulodigastric nodes. The posterior tongue also drains into the upper jugulodigastric nodes.